Hi, it's Dr. Dave McCreary here from POCUS UK, and in this video I'm going to be showing you lung pathology that you can and will find using POCUS. So for this we would have the child sat on the carer's lap or bed. We would use the high frequency probe, providing us with the best spatial resolution but limited depth. We would be scanning anteriorly and posteriorly in a dynamic fashion, trying to cover as much of the lung as we can, from medial to lateral, and never forgetting to scan into the axilla. So for the first pathology, I'd like to show you an example of consolidation, what we describe on POCUS as subpleural consolidation. This first arrow represents the normal pleural line. You can see it's lost the bright appearance as normal, and that's because the interface between aerated tissue and the actual reflector that is the pleura has been lost. Everything beneath the pleura here is beginning to become consolidated, so it's taking on a semi-solid appearance, and therefore we lose that interface. Instead, we get this ragged line beneath the consolidation representing the transition to normal aerated lung, and that's called the shred sign because it looks like shredded up tissue paper, very, very ragged or irregular. It's also known commonly as the fractal sign, and if we see this, we know that infection is beginning to take hold. So just again, appreciate in this view, we've got about a 2 centimeter region of grossly abnormal lung tissue. It's much more solid in its appearance, becoming quite organized, and that would represent infection. Now, everything's a spectrum in POCUS, so we see one degree of consolidation progress into something else very quickly, and here we would see an example of an air bronchogram. So this would be the same thing as described on a chest x-ray. We're literally seeing the reflective air within the small bronchi with a background interface of solid tissue, so consolidation highlighting that air within those spaces. In this case, it's moving dynamically with each breath from the child, and this would be typically consistent of consolidation. This is quite an impressive example, and if you can get the child to breathe heavily, you'll see it often. Now, we can differentiate dynamic air bronchograms with those of static air bronchograms, which I'm going to be showing next. Some people feel that this is a good differentiator for collapse versus consolidation. So in a dynamic air bronchogram, we can clearly see the movement, implying that the lung is still functional as opposed to completely collapsed, albeit very consolidated. In the second example, you can see that there's a lot less movement. And then in the third, you can possibly appreciate that there's no movement at all, showing that it's a static air bronchogram. The darker tubular structures within the lung tissue are what we call fluid bronchograms and would also represent consolidation. Now, all of these appearances are consistent with what we call hepatization, and that is where the lung tissue takes on a solid appearance on echo, in terms of its echo texture, and it's obviously taken from the name that it resembles that of the liver tissue. So here we can see in this example, we're scanning either probably spleen there, and we can just about make out that the lung above it is separated out by the diaphragm, which again is a lot less of a bright line because of the loss of those interfaces of the aeration. But we can appreciate the gap in between, suggesting that it's not all organ. In other words, that we've got the lung above it, and we can see that that lung looks grossly abnormal. It's fully hepatized, and you've got to be very careful in making sure that you don't just label this as liver or as spleen. In this next images, we can see it's really hard to differentiate between the actual liver, what I believe is liver in this image, and lung tissue. What we can then see is a parapneumonic effusion. So whenever we have pneumonia, we were finding an awful lot of parapneumonic effusions in the winter of last year when we had lots of pneumonia come in. And these can be small or they can be large. A small one would be, less than 2 centimeters surrounding the consolidation. But in this next example, we can see a very large example of a pleural effusion. The effect of the fluid in that pleural space causes the lung tissue itself to collapse down, and this can produce some very unusual appearances as shown here. The term we typically use for a collapsed lung flapping around within the pleural effusion is called the jellyfish sign. Now, typically, this is because it would look like a jellyfish's, well, whichever anatomy the jellyfish has. I actually had to pause the audio of the video to understand what a jellyfish was made up of, but it looks like some sort of a sea creature. I've heard these appearances look like mermaids' tails, dolphin fins, anything like that. So typically what we're seeing is the residual solid lung flapping around in this large effusion, and presumably the pressure in and around the pleural space caused by the effusion leads to such a significant collapse, reducing the residual lung to just a small flap. Hopefully this is something you would all recognize and appreciate the significance of. Now, at times these anechoic effusions can be a little bit misleading and difficult to differentiate whether it is truly fluid that you're looking at or lung tissue beneath. So one nifty tool that I've utilized in the past is something called the sinusoidal sign on M mode. What we do for this is to place the M mode cursor through this anechoic region, which obviously plots movement or distance against time on the two axes. Here, with the motion of that visceral pleural edge moving within the pleural fluid, we can see a sine wave pattern or an M wave pattern, which produces this graphical display on the M mode. And this highlights to us that it is in fact fluid within that region. It's the inward and outward motion of that lung tissue within the anechoic effusion. So I've found that helpful 1 or 2 times in the past, and maybe that's something you can use if you're uncertain about what's going on. Now, we know that not all lung effusions are equal, and if we were to see an appearance much like this, we can obviously appreciate the anechoic or hypoechoic fluid, but we can clearly also make out that we've got septations in a very organized type effusion going on. So this would be bad news for the child, and this would imply an obvious empyema, one that's likely to require drainage or possibly a VATS type procedure. I hope you've enjoyed the video or found it useful. If there are any ideas for videos you'd like to suggest, feel free to do so. Take care.